Assalamualaikum and good afternoon. I'd like to invite the audience to just kindly stand up. I'm just about to announce the arrival. Not yet. Oh, okay. Sorry, belum. Sit down. You can still sit down. Apologies. Wrong seat. Okay. Good afternoon, everyone. I'd like to kindly invite the audience to just stand up for the arrival. I would like to welcome the arrival of our Dean of the Faculty of Medicine, University Malaya, Professor Dr. April Camilla Roslani, accompanied by the Honourable Professor Dr. Choo, Professor of Ophthalmology, Faculty of Medicine, University of Malaya. I would like the audience to remain standing up as we will start this inaugural event with a national anthem followed by our University of Malaya song. I invite you to take a seat, Prof. April and Prof. Choo, and the audience. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh dan salam sejahtera diucapkan kepada semua hadirin yang dihormati sekalian. Mencari timba si anak dara di bawah sarang burung tempua. Salam sembah pembuka bicara, selamat datang untuk semua. Selamat datang ke Syarahan Perdana Profesor Dr. Choo pada hari yang berbahagia ini. Izinkan saya bertutur dalam bahasa Inggeris untuk sama-sama menghormati dan meraihkan para hadirin dari luar negara. I would like to extend our warmest welcome to the Dean of the Faculty of Medicine, University Malaya, Prof. April Kamila Ruslani, the Honourable Professor Dr. Choo Professor of Ophthalmology, Faculty of Medicine, University Malaya, Yang berbahagia Profesor Datin Hajah Dr. Nurlina Muhammad Ramli, Head of the Ophthalmology Department, Yang berusaha Dr. Jamalia Rahmat, Consultant Pediatric Ophthalmologist, Head of Ophthalmology Department, Hospital Kuala Lumpur. Yang berusaha Dr. Muiz Mahyudin, President of the Malaysian Society of Ophthalmologists. Yang berusaha Profesor Dr. Hajah Shatriah Ismail, President of the College of Ophthalmologists, Academy of Medicine of Malaysia, Head of Department of Ophthalmology and Visual Sciences, University Science Malaysia. Distinguished guests, professors, doctors, ladies and gentlemen, who are joining the inaugural lecture virtually and physically today. I am Irina, and I am honoured to be the Master of Ceremonies for the inaugural lecture of my supervisor and teacher, Professor Dr. Choo A professor's inaugural lecture is one of the university's most cherished traditions. This lecture honours the professional journeys taken by our professors and provides an opportunity for them to share their wisdom, inspirations, and philosophies. We are grateful to be here today as an audience for this inaugural lecture by Professor Dr. Choo a dedicated and passionate senior consultant pediatric ophthalmologist in University Malaya. Today, Professor Dr. Choo will be sharing her journey in the field with us in this inaugural lecture entitled Keeping Up with the Pandemic of Retinopathy of Prematurity, a Blinding Disease of Premature Infants, sharing 3 decades of experience with this disease in Malaysia. Without further ado, I would like to invite the Dean of the Faculty of Medicine, Professor Dr. April, to chair the lecture and subsequently to introduce Professor Dr. Choo Please welcome Prof. April.
Yang berusaha Professor Dr. Choo Professor of Ophthalmology here at the Faculty of Medicine, University Malaya. Yang berusaha Dr. Jamalia Rahmat, Chair of Pediatric Ophthalmology Services, Ministry of Health Malaysia. Yang berusaha Dr. Muiz Mahyudin, President of the Malaysian Society of Ophthalmologists. Yang berusaha Professor Dr. Hajah Shatriah Ismail, President of the College of Ophthalmologists, Academy of Medicine of Malaysia. Distinguished guests, colleagues, ladies and gentlemen. Assalamualaikum, salam sejahtera and greetings to you, whether you be with us here physically in TJ Danaraj Auditorium or whether you are online. It is said that to have good eyesight is to have a window into the soul of the world. The life's work of today's inaugural lecturer has been to ensure that everyone, from childhood to adulthood, is afforded the best eye health possible. Professor Dr. Choo is an alumna of University Malaya, class of 85 to 90, and is currently a professor of ophthalmology here at her alma mater. She has served in many sectors of the Malaysian healthcare system, beginning as a house officer at the then University Hospital, subsequently serving in Hospital Mentaka, Ministry of Health, before secondment to the Ministry of Defence. While at the Lumut Naval Base and Kinrara Hospital, Puchong, she treated civilians as well as personnel and family members of the Malaysian Armed Forces. When she returned to the Ministry of Health, she embarked on her first job as a registrar in ophthalmology at Hospital Kuala Lumpur in 1993. This cemented her love for the specialty, and in 1995 she enrolled in University Malaya's Master of Ophthalmology. Her training saw her participate in various presentations, in conferences in Malaysia and Singapore, and ignited her passion for academia as a career. Although she returned to Ministry of Health to complete her gazettement as clinical specialist at the Hospital Kuala Lumpur, she eventually made her way back to University Malaya as an academic. Recognizing the limited expertise locally in pediatric ophthalmology, she chose to make pediatric ophthalmology and strabismus care her niche area, training at the Royal Alexandra Children's Hospital in Sydney and in pediatric glaucoma at Westmead Children's Hospital. But never one to rest on her laurels, and recognizing the need to understand the underlying causes of pediatric ophthalmology disease, she recently completed the Genetics and Genomics in Medicine course from the University of Sydney. She was the first fellow of the College of Ophthalmologists from University Malaya's Ophthalmology Department. She runs ophthalmology clinics for both adults and children at University Malaya Medical Centre, in addition to conducting monthly multidisciplinary clinics for craniofacial disorders, as well as retinopathy of prematurity screening weekly at the NICU with the pediatric ophthalmology team. She is often consulted on genetic eye conditions. Recognition of her expertise is unsurprising given her rich research portfolio. Research interests include adult cataracts, effect of diabetes mellitus on cataract surgery outcomes, corneal layers, orbital and neuro-ophthalmic diseases, and various pediatric diseases, foremost of which are retinopathy of prematurity and craniofacial disorders. She has served as principal investigator and co-investigator for research grants amounting to over 1 million ringgit, and is currently involved in industry-sponsored research on the use of atropine for childhood myopic control. Her peer-reviewed publications and invitations to lectureships reflects her research interests and subspecialty fields. She is therefore sought after as a reviewer for many ophthalmology journals covering glaucoma and pediatric topics, including the Malaysian Journal of Ophthalmology, International Journal of Ophthalmology, Ocular and Therapeutics Journal, Neurology Asia, Journal of Glaucoma, and Journal of American Association of Pediatric Ophthalmology and Strabismology. Henry Ford once famously said that anyone who stops learning is old at 20 or 80. Anyone who keeps learning stays young. Prof. Choo certainly embodies this ethos. Currently involved in a collaborative research for her PhD at the University of Sydney, she has been actively liaising with SaveSight Institute of University of Sydney that has seen external examiners, external reviewers, and adjunct teaching staff come in to participate in continuous medical education. Therefore, constantly seeking to pass on her knowledge and expertise, Prof. Choo has been the main undergraduate coordinator for ophthalmology from its early years through the new integrated curriculum until the present UMMP curriculum. When she became the head of Department of Ophthalmology in 2010, she was the chairperson of the Malaysian University's Conjoint Committee for Ophthalmology that ironed out the initial ongoing difficulties of the conjoint examinations between the three universities conducting the program. From a training perspective, she has also helped to set up the fellowship training program in this subspecialty, receiving both overseas as well as Malaysian applicants. It gives me great pleasure, therefore, to welcome Professor Choo to speak to us on her 3 decades-long experience in dealing with the pandemic of retinopathy of prematurity. Professor Choo, the podium is yours.
Thank you to Professor Dr. April Camilla for the kind introduction, and also for allowing this event to happen, because it's the first time for ophthalmology to hold an inaugural lecture. Good afternoon to my distinguished guests, who I know have moved your schedules to be able to come here and attend this lecture. A lot of the guests here are people who have served the university, people who have contributed to the training of ophthalmology in Malaysia. So we actually have the president of the College of Ophthalmologists coming all the way from USM to attend this event, Professor Kshatriya, and the Chief of Services for Pediatric Ophthalmology, Dr. Jamalia, and sorry, a bit nervous, and the President of the Malaysia Society of Ophthalmologists, Dr. Muiz Mahyudin. These two are actually our alumni, and we're so proud of them to have reached such a leadership position. And of course, we have our first director of UMERC, Dr. Ken Fong, who is also an academic staff in UM. Dr. Ahmad Fauzi, who is our ex-head of department when he has actually stopped some clinics just to attend this. I bugged him during his holiday in Sabah. Dr. Noraini Nadio, my teacher during my master's years. Thank you for coming. I tried to get Professor Fadila, but she sends her apologies because she's quite difficult for her to move about. She was the person who employed me to come in as an academic staff here. And also Dr. Noor Hafiza, who is now chairing the current CPG together with Associate Professor Safina Skeldin from UKM. And Dr. Fazila Wati, who is my esteemed colleague, who is the head in Klang Hospital Eye Department. Welcome everybody to this lecture. Without further ado, I will now proceed with my lecture. So before I even begin, I'd like to acknowledge and thank the production team. These names are a long list. They have been working very hard, 6 weeks, I think, before this actual event, putting this together. Of course, we have Dr. Irina Tenang, who was the MC, who is the current MC now as well. She made it back from her awards ceremony just now. And of course, we had photo sessions, so you see some very nice touched-up photograph. Right. So my journey begins with the MBBS course in University of Malaya. I found some old photographs from the freshy years right down to the time we were told that we all passed the exams and we were cheering in the lecture hall. Of course, in between, we also participated in a lot of social events, especially in the first 2 years of our course. Some were formal events, and some more of an entertaining kind of event. Although we worked very hard in those 5 years. So as mentioned just now, we all went through our compulsory service to UH, to the district hospital, as well as my 2-year service with the armed forces, which it's been very memorable 2 years, where I got to meet a lot of people outside the medical profession. And then it was back to Kuala Lumpur Hospital to get my qualifications and to be able to embark on fellowship training. This was my first fellowship training at the Royal Alexandra Children's Hospital. My preceptor is Professor Frank Martin, who I think is probably watching this on YouTube. He has been instrumental and my mentor all these years. Without him, I would not have achieved, half the things that I set out to. Yeah, this is something I was very worried about, balancing. So after my training, I gained a lot of confidence to do complex screen surgery, for which I participated in presentations abroad. At that time, my children were quite young, so they weren't able to join me most of the time, so that's where my husband came in. So after that, there was also a motivation to do publications on cases, and that was also the year where I did my first retinoblastoma of prematurity studies. Onwards from there, there was a lot of involvement with the Asia Pacific Academy of Ophthalmology, with speaking invitations to Bali, to Beijing, and to Sydney. And recently, I was very honored to be standing among very distinguished speakers and researchers for the disease ROP. For those who can recognize, this is actually Dr. Michael Chiang from the US. He's a director of the National Eye Institute. So very honored to have been among speakers in that symposium. So of course, teaching was a major part of our duties as academic staff. So we teach medical students, and of course, a lot of our master students have come through the years, spending some spent 2 years with us, some 4 years. And they have been a very important part also of the service in the University of Malaya Medical Center, or PPUM. It was very lucky that I was able to attend this last graduation that I probably will be attending for the department, and these were some of the trainees. And so of course we always have events where we have dinner to celebrate our final year graduating ophthalmologists. And also a large part of our work involves clinical work, which we do at the PPUM, where we manage a lot of diseases like, besides ROP, retinoblastoma, pediatric glaucoma cases. And since 2012, we were very actively running a multidisciplinary clinic for craniofacial syndromes. So maybe I'll just take a little bit of time to show this service that we have. So of course it's a team effort from ophthalmology. This is Professor Noliza Khalidin, and this is Dr. Irina Tenang, who we kind of take turns now to run this weekly, monthly clinic. And then in 2013, the opportunity to do a second fellowship came with sabbatical leave abroad, where I was taught to do a lot of procedures by Professor John Grigg. And it was a very good experience, and the number of cases that we managed throughout that year was all just purely glaucoma cases. So at that time was a good timing because my daughter had already entered university in Sydney. My son was about to go into boarding school there the following year. With that following, there was this international collaboration that was encouraged by the former dean, Professor Dato Adiba Kamaruzaman. And so Professor Tengku Ain Kamaldin accompanied me to Sydney to visit the Safe Sight Institute to formulate this collaboration. This is the Frank Bilston lab at the Safe Sight Institute. It's housed inside the Department of Ophthalmology. So we were very impressed with the setup. and probably we would work towards having this in our center. So then this led in 2017 to the offer to do a PhD course at the University of Sydney, funded by the Australian government through University of Sydney. So the course is a part-time course, and it is still ongoing. This is Professor John Grigg, my supervisor. In the second year of the course, I had the opportunity to be in Sydney for the whole year to join the trainees in the university, the very young people that were doing genetics lab work. So that was interesting, going back to school again, rushing for classes. Of course, there was a committee formed by the MSO, is an advocacy board, to help curb the explosion of myopia cases in children, particularly made worse in the 2 pandemic years. So only this year we were able to do face-to-face an activity where we introduced or launched the mascot, this little owl here. So I would like to end this part with just showing a composite of my friends in the MBBS class. We have somehow kept in touch, argued on the WhatsApp group. So there's 2 of them who are still in service with the university. That's Dr. Saleh, as well as Professor Vigneswaran. Okay, now on to my lecture on retinopathy of prematurity. The topic of my lecture is keeping up with the pandemic of retinopathy of prematurity. It's a blinding disease of premature infants, and I would like to share 3 decades of my experience with this disease in Malaysia. Somebody made a remark, oh, for once it's not a pandemic of COVID-19. But this pandemic is there. It was there before COVID. So what is retinopathy of prematurity? It's only seen in premature infants because at the time of birth, the retina has yet to fully develop. So it's actually a proliferative vascular disease of the immature retina. When a baby is born premature, the blood vessels in the retina has not fully developed yet because it takes 36 weeks in utero for the vessels to reach the nasal retina periphery. And by 40 weeks only, the retina is mature. So any baby that comes out premature will have this problem of a large area of non-vascularized retina. Of course, those who are familiar with our field, the pediatric ophthalmologists, we know that there are actually 2 current theories for the development of this disease, but the main thing is that there is a vasoproliferation, which involves presence of vascular endothelial growth factor. VEGF causes very tortuous vessels that we can see in the eye of the premature infant, as well as presence of new vessels and iris vessels dilation and rubeosis. If this condition is not controlled early, it leads to more fibrovascular proliferation, and finally this fibrovascular tissue will contract and cause whatever retina that was formed to be fully detached and form a scar or a clump behind the lens. That's why this condition is known as retrolental fibroplasia in the early days, because all they saw was just this white mass behind the lens. So there's a lot of risk factors that have been studied. Some of the main ones are the small gestational age and the small lower body weight at birth. Oxygen is a big thing. The use of supplemental oxygen, the use of higher oxygen, or the long duration of oxygen therapy, as well as mechanical ventilation. Other factors are maternal factors that are investigated, and of course, infant comorbidities. These are now more studied, things like anemia, transfusion, the use of erythropoietin, thrombocytopenia, patent ductus arteriosus, necrotizing enterocolitis, intraventricular hemorrhage, sepsis, etc. So what are the three pandemics of retinopathy of prematurity? The first pandemic happened in the 1940s and 1950s in developed countries. Here it was found that a lot of these children, especially those who were nursed in private hospitals, developed blindness. And it was in the 1950s that Campbell and Patz made separate association linking oxygen to the development of this disease. So in private hospitals then, there was free flow of oxygen to be given to the neonates. And as a result, a lot of them became blind from the disease. So when this link was proven, there was an effort in the 60s, late 60s, that to curb the use of oxygen on premature infants, as well as the need for regular eye examination. But then there was no treatment at that point. But because of this curbing of oxygen, the pandemic was largely controlled. And then in the 70s, the second pandemic occurred, also in industrialized countries, because of improvement in neonatal care. It enabled smaller and more premature infants to survive. Of course, there was a need for better surveillance, and there appeared to be a need for effective treatment. There were anecdotal reports of effective treatment, but it wasn't until 1986 when the cryo-ROP study was planned that this became a landmark clinical trial, because it proved that if you proceeded to do cryotherapy, a lot of the eyes were saved from blindness. Now, since the 1990s, we are currently in quite a bad pandemic. It's the third pandemic, which involved middle-income countries like Malaysia and very developing countries. So here there was improved survival because pediatric neonatal service was more advanced, more money is allocated, but there was lack of oxygen monitoring. And also, it did not help that in 2010, there was a big effort by the pediatric group, neonatologists, to actually increase oxygen saturation targets. That means the level of oxygen delivered to these infants while in their care. The first study was support. So this actually is the reason why we are also seeing very bad cases today in even our advanced facilities that we have here. So because of these problems, we are seeing aggressive disease in larger infants that we've not seen before. And of course, we were very happy that there was treatment in the form of anti-VEGF injections. However, this treatment induced a state of non-vascularization. And so the risk for the disease is still there for a very long time, and it actually increased the burden of our workload. So the two big studies during this era, of course, is the ETROP study that was published in 2004. It introduced earlier treatment, and the BEAT-ROP, which is the first trial that used anti-VEGF injections into the eye. So just a little bit about how cryo-ROP helped end the second pandemic. So this study involved infants that were born with birth weight 1,251 grams or less, that had survived the first 28 days of life, and they had to have what is known as threshold disease to be able to come into the trial. And they were recruited since January 1986. And what is threshold disease? I think the exam master students must know this because it comes out in exams. it is stage 3 ROP in zone 1 or zone 2, where there's 5 contiguous clock hours or 8 cumulative clock hours involvement together with plus disease. So in this trial, the babies were randomized to either no treatment or cryotherapy. When I joined PPUM, as well as when I returned to Kuala Lumpur Hospital, we still had the cryotherapy machine. Although we had already moved on to diode laser, that cryo machine was invaluable because if there was a problem with the diode laser, we could still go back to cryotherapy. So this was a landmark study. After 3 months of recruitment, they actually stopped recruiting, and there was an expedited publication because there was definite improvement of outcome. And so the recommendation was for treatment with cryotherapy. And the cryotherapy procedure was proven to improve outcomes by 75%. So when I completed my gazettement in the year 2000, we were, as I said, we were just transitioning between cryotherapy and diode laser treatment. So diode laser treatment is a bit difficult to do, but it's actually, once we have mastered it, it's a much gentler procedure on the infant eyes, because cryotherapy is ice applied from outside to reach the retina, but in diode laser, we can actually point to where in the non-vascularized retina that we want to treat. But of course, it is very bad for the neck as well as the back. So there was, in this trial, the early treatment ROP was devised because in the cryotherapy series, there was still a quarter of the patients that did poorly, despite a response to treatment. Majority of them, about a quarter of them, did not have good enough vision that they could get a driver's license when they grew up. So early treatment was suggested, where we actually treat the children before reaching threshold. So this is the term that we call pre-threshold. So in this clinical trial of 499 infants, it was again proven that early treatment was actually better. And so now we have the indication of treatment which is known as type 1 ROP. Again, for master students, this is something that we expect that you'll be able to answer in the exams. So the next study that was quite good, that came out timely, was the BEAT ROP trial. This is not industry sponsored, but this was based on success by South American and Latin American countries where they could not afford the diode laser. So they proceeded to do intravitreal injection of anti-VEGF, which helped to control the disease, especially the aggressive ROP. And the use of the anti-VEGF for this is the bevacizumab, which is an anti-VEGF that is used for treatments in colon cancer. But the amount used is very small, so it's very cost effective. So this trial was able to prove that there was a very beneficial effect if the disease in zone 1 was being treated with anti-VEGF versus the conventional laser. But it did not show any benefit in disease in zone 2, so we're better off to do laser for these cases. The good thing about anti-VEGF is that it reverses the disease and it allows retinal vessels to grow further out. So we have more normal retina to have for the child. But the downside of this condition is that the VEGF effect somehow causes the retinal vessels to stop advancing. So we still had an area of non-vascularized retina that predisposes these infants to reactivation of the disease. So if it reactivates, we'll have to proceed with secondary treatment. And the follow-up is very prolonged for anti-VEGF cases. As those of you who have come and done ROP rounds with me would know, if we just proceeded to do laser, then it's almost end of story. By about 40 weeks, we could discharge the patient and tell the parents, that's it, the disease is controlled, it would not come back, and probably we'll see you in 3 months' time for one checkup and at 6 months' time, and maybe yearly. But for anti-VEGF patients, you cannot do that, because as long as there is an area of non-vascularized retina, we have to continue subjecting the child to a very uncomfortable examination. So it's a big struggle between the child and the examiner once the child is older. So now we have more anti-VEGF studies, mainly industry-sponsored studies, to try to get FDA approval. Rainbow trial is one of the studies. It did prove that the children treated with ranibizumab had a better outcome compared to laser. And treatment, however, the treatment success rate for zone 1 patient was only 67.9%. That means the recurrence rate was quite high. And we see that in this study, they measured the concentration of ranibizumab in the serum. This means we injected the drug into the eye, but it has escaped out into the peripheral circulation. And this is what we are very worried about, because we don't want anti-VEGF effect on the immature lung, on the immature brain. So we actually don't know the long-term outcome of this treatment, even though it has got FDA approval and all. And we look at one of the more recent study comparing the outcomes of Rainbow trial. In the 2 doses used for ranibizumab, the percentage of reactivation, means recurrence of the disease, is about 33% for the higher dose and 36% for the lower dose, whereas for laser it is 18%. So we have to see more long-term effects, but of course when industry pushes, they do get results. The second industry-sponsored study is the Firefly as well as the Butterfly study. So they employed aflibercept to be given into the eye in a much smaller dosage than adult eyes. Now the concern here is the same for all anti-VEGF, but there's further concerns because this drug induces inflammation in adult patients because it is a chimera drug. So one of the part of the drug is actually formed through animal source. So to be injecting these into the eye really worries us because, as you know, litigation comes for about as long as 20 years, 25 years. So what may be safe today, in the future, we don't know. Right, so let's move on. Why is there interest in the middle-income nations? It's estimated that over 32,000 infants are impaired, have mild to moderate vision. 50% of those visually impaired from ROP were born in middle-income regions. Asia contributes 52% of the total number of preterm births, and this is followed closely by sub-Saharan Africa. And so we can see this area here contributes the majority of preterm birth. And this is where the problem lies, because if you see the outcome of severe ROP, only 5% high-income country infants develop severe visual impairment. But if you look at Southeast Asia and the Pacific, we get figures like 11.7% develop blindness from the disease. In South Asia and in Africa, the percentage blind from this condition is 13%. So it is a big problem for this region and for us. Now, how do we screen and treat retinopathy of prematurity? Every week, my fellow and I, or with Prof. Nolisa, we will go and do ward rounds. We have the nurses prepare the babies beforehand, dilate the pupils, make sure they are not fully fed, just fed, so that when we do the examination, they don't throw up. And if we detect a case with ROP, we have to see these babies a lot more frequently. And if they end up with type 1 ROP, then there's a big planning to get the pediatric team, the nursing team, to set up an area in the ward for us to do the treatment. It's very nice to say, let's go and book theater, send the baby to the operating theater. But the concern is that these are very, very young infants with very, very poor lung function. So most of the time, it is more comfortable for the pediatrician to take care of these children in their ward while we do the treatment, whether it is in NICU or PEDS ICU. So it's actually the safest option. So this is just a little interlude of some historical aspects of ROP. So the first successful treatment was actually in 1968 by Dr. Makoto Nagata. He treated stage 3 ROP with the xenon arc photocoagulator. It's something very historical. I have not seen it myself. Yes, but these anecdotal reports were what led to the cryo-ROP study. So here's a very interesting alternative method of screening ROP in the days before the indirect ophthalmoscope, which we wear over our head.
The equipment that we use for this examination, you already have most of it available. We use the cyclomidrol drop for dilation of the infant's pupils. This is a combination of 0.2% cyclopentolate and 1% phenylephrine applied 45 minutes and 30 minutes prior to the examination. A topical anesthetic is necessary for the application of the infant gonioscopy lens, which you see here. Finally, a direct ophthalmoscope. The only difference here is that the head of the ophthalmoscope must facilitate single dioptric steps from +6 to +16. The lens is available in 10.5 millimeter and 11 millimeter base. The 10.5 millimeter is best for use in the nursery, but in children who are 3 months of adjusted age or older, for example, the 11 millimeter base lens may be more practical. And now we'll take you to the intensive care unit and...
So what I wanted to show is that, of course, we are not in the era where we do the examination of the infant eyes with the direct ophthalmoscope. I think none of us have actually seen it being done, but maybe the people who train in Canada would have seen it because this Professor Warren Hindle is from Calgary. But the method would require a lot of skill and also the placement of a contact lens and very close contact between the examiner and the infant. So what is the situation like in Malaysia? As we can see from this National Eye Database report over 2002 to 2012, there's been an increasing number of cases of premature infants subjected to retinopathy of premature screening. So in Malaysia, in the 2008 neonatology report, there was, in selected hospitals, they gathered for this study, 34.2% of cases developed ROP. And in blind school studies, we see that 20.8% had severe visual impairment of children aged between 7 to 17 years, which were related to a retinal cause. Then in 2012, our center published a paper where they looked at 24 blind schools in Malaysia, and 17.4% became blind or were severely visually impaired due to ROP, and there's an increasing trend, so it's worrying. What about in our hospital? So we presented a case series from 2003 to 2005, our cohort. We actually saw an increase in the number of stage 3 ROP. So stage 1 and 2 are mild disease. Stage 3 is the disease where we intervene, because if we don't, then they become stage 4 or 5, which means the retina is already detached. And when we look at our figures, we noted that in PPUM, we had increasing number of infants that had birth weight below 750 grams. These are very, very small babies. Of course, in 1990, one of the first publication reporting on incidence of ROP in PPUM, the incidence was only 15%. But when we did one in 2008, we had an incidence of 29.18%. So a third of the cases had developed ROP in our cohort. And the incidence rate for those below 750 grams was 76.2%. So there is another upcoming neonatal report that reported on selected hospitals in KKM, the Ministry of Health, and this time the incidence was only about 20%. But in our recent publication, we are still having 29.1% and 29.3%. So one of the reasons is that because we have a higher proportion of smaller infants. So if we look at another report coming out from East Malaysia, when they look at extreme low birth weight infants, these are infants weighing 1,000 grams and below, the incidence was 53.3%, just over half. So our extreme low birth weight incidence is also about there. So the focus is also on what is the birth weight that we screen when we compare incidences. So what did I learn in Sydney? When I was there, I was introduced to these wonderful, small, gentle instruments that is more suitable for very premature babies. And this is called the Flynn indenter. I think now most of us use it, because when I first started in ophthalmology, we used adult indenters, which are quite big, and sometimes we use modified paper clips to do the indentation. So when I came back, we requested the NICU to purchase these instruments so that we can follow what other hospitals internationally use. And I also jumped the gun a bit. I implemented early treatment, that means at pre-threshold, before the publication came out in 2004, mainly because we don't have pediatric vitreoretinal surgeons to deal with stage 4 and 5 disease. So we wanted to make sure that we don't lose as many eyes as we could. And I think we have been quite successful in that sense. Okay, looking at the risk factors for the disease in our extreme low birth weight cohort, what I wanted to point out is that in that study, we only saw zone 1 disease in those who were below 750 grams. So this was the time, almost a decade back, where, okay, we see all these typical aggressive ROPs that were usually below 750 grams. So if we saw a bigger baby, we would be quite sure they don't have this aggressive disease that needed anti-VEGF injection. This is our first fellow of our pediatric ophthalmology program. He's from Iran. He was our master's student. Upon graduation, he joined us to do his training. Now, in the last 5 years, we are seeing this aggressive disease in larger infants. 1,875 grams, and this one was from UKM. I think this is a 1,500 gram infant. So we also had 32 weekers that weighed 1,400 grams that had this aggressive disease in zone 1. So this was very worrying, because now instead we can't tell the parents, oh yeah, baby is very small, that's why high risk, but my baby is over 1,000 grams, right? So we went back to look at risk factors again. We had this huge cohort of 600 infants that we screened, and we discovered that midway after 2010, the oxygen saturation target were more liberal. Instead of keeping oxygen level below 90, I think it was 88% to 92%, this time our neonatologists confidently increased the oxygen saturation targets up to about 95%, and sometimes our nurses do physiotherapy and suction, and these babies go into a very bad apnea, and so then they increased further the oxygen. So when we go into our NICU, we see a lot of babies with 99%, with 100% sometimes, and it frightens us. So we were able to show in our study that higher oxygen saturation target increased the risk by 2 times. Of course, the other things are like sepsis, ventilation, and birth weight, and gestational age, and presence of heart disease. This one is a study from Sarawak. They were only able to show that birth weight and, again, gestational age was the most sensitive predictor. But because we had the luxury of comparing two epochs where the oxygen was very strictly kept at a lower level to compare with the newer era of higher oxygen, we were able to show this. So we went on to look at infants who were over 1,000 grams in this study, just to see if oxygen was also a risk factor for ROP in larger infants. And we found that in epoch 2, where the oxygen target was much higher, for these larger infants, there was a 2.7%, not 2.7 times risk of the disease. So again, oxygen here was also a problem, besides sepsis. And the predictability of for the ROC curve for this study was 0.72, which was quite high. So now I move on to my involvement with the clinical practice guideline for retinopathy of premature screening. That was first started by the late Dr. Joseph Alagaratnam. We published it in 2005, involving ophthalmologists in the country that were actively doing ROP screening. And now Dr. Nur Hafiza is leading a second edition, which is long in coming because there has been newer procedures, and also we are seeing unusual cases in bigger infants. So we hope to launch this second edition, which has just been presented to the Malaysian Medical Council. This time the CPG has had extensive reviewers from both within the country as well as overseas, and we hope to launch it in 2024. And now the recommendation is that now we actually have to screen babies that are heavier, 1,750 grams, to ensure that we are not missing the big babies that are developing bad ROP. And of course, there's the follow-up of cases is important because we want to stress that as long as there's non-vascularized retina, we have to see these babies. What about the international collaboration? As it happens, we published our paper recently. And before we did that, I presented this in APOS which is the American Association of Pediatric Ophthalmology and Strabismologists, as an awardee for the grant that is awarded to ophthalmologists in this region. So we shared our work, and I got to have some pictures taken with some stars in the field. Of course, as part of this collaboration, we also had some findings on premature infants from our cohort, which we published, that would actually set a reference for our local population on how the corneal thickness behaves as the child matures and how the size of the cornea is. And so we hope to get some publication out soon. Yes, there are also diseases that are seen in premature infants in our cohort. So we did a few publications, and this is very interesting. We treated infantile hemangiomas with propranolol, which has anti-VEGF property. And within weeks, we can see these large size hemangiomas shrink quite rapidly. So there are studies now using beta blocker to try and prevent or to try and treat ROP. But so far the results are unequivocal. I think there's a trial ongoing at the moment. So what about future research? We would like to look into the genetics. A lot of the studies actually involve quite small cohorts, except for Hartnett's, which had such a huge number. And the variants that they found was the BDNF, the brain-derived neurotrophic factor, which was associated with severe ROP. So this factor is quite popular. If you have stress, you have reduced BDNF. If you exercise, you increase your BDNF. So it helps with memory, it helps with preventing aging. So anyway, there's still no application yet. No drug has been invented yet to stem this condition. We know the USM group found NDP gene in ROP in one of their study. So we have looked into the SART gene for an association, but again, initial finding was there was some association, but it has not shown when we did a larger number of infants. So that ends my lecture on ROP, mainly focusing on what we are doing and what we have done. And so I thank you for your attention, but before I get off the rostrum, I would like to acknowledge again the Dean of Faculty of Medicine, Professor Dr. April Camilla, for acknowledging our contribution by enabling and chairing this for the first time for Ophthalmology Department. Professor Dr. Norlina Ramli, who is the current head of department, who continues to support my pursuit of study in this disease. I would like to also thank Professor Dr. Fatila Jais, who was very important as she brought me into the department here. Those long years ago. All my wonderful colleagues in the department, we are a very small department, but we are very cooperative. And this has enabled all of us to take sabbatical leaves in turn and all my research leaves. It began with the tenure of Professor Dr. Nolisa Khalidin, who gave her support for the collaboration, and of course, Prof. Tengku Ain, for initiating that initial Safe Site Institute work. Special gratitude to Dr. Irina Effendi, who is our current trainee, and the good news is she's going off next year to Australia to do her overseas fellowship. She was going for interview for the following year, but she was offered a year ahead. Yes, the staff of iClinic, who helped during our difficult examination of the ROP babies. It's very difficult because by the time the babies come to outpatient, some of them are on oxygen still, but they are already very big and struggling away. So it's very harrowing to examine them in the clinic. We tried to put a pulse oximeter, but I usually turn on the lights. And I want the babies to cry, because if they become quiet, they actually may be apneic. I think it happened to Prof. Nolisa. She had to run off with the baby to the ED, because during the examination, the baby actually became apneic and unresponsive. So we're actually very scared when we do the examination. Yes. Also, I would like to acknowledge the nurses and the consultants and doctors of the NICU ward and the PEDS ICU wards. They have been an instrumental and very crucial part, because they help us to sedate and monitor the baby as we do our examination, and also the laser procedure and the injections. Of course, these are my pediatric ophthalmology colleagues. We do try to get together, but there's only 30 of us, including the current fellows. So we are a very small group. We're trying to expand the group. And my old teachers from HKL days. This is Professor Frank Martin. He's my mentor from back at my first fellowship, very much. I don't think he has aged much, actually. This is recently, last year, after we all got out of pandemic and we were able to meet up. Yes, he continues to advise me, and he has been very important for a lot of us, because he has taught many people who practice in Malaysia. I think I might have missed some names, but yeah. So he's like our big sifu. Finally, my utmost gratitude to my husband, Dr. Ho. He's an obstetrician. He was a UKM lecturer, but he had to sacrifice his ideals to be academic, because he has to feed his family. So without his encouragement, because his experience in academia, he really helped me, have a mindset of what is expected of academic career, in the academic career. And he helped me take care of the 2 kids when I was away at training. My children, unfortunately, are not here to attend this physically. I hope one of them is at least on YouTube. So Anne is my eldest. She's working in the colorectal unit. She wants to be a surgeon. She doesn't want to be an eye doctor. And because actually ophthalmology is very competitive. Tim, my son, is now in the 4th year doing his medical school. So this was the last holiday that we had just before pandemic restrictions. It was to celebrate my son graduating from high school. So I put this picture up because it took us 2 years before I could hug him, because he was stuck in Western Australia. Western Australia was like a different country to the rest of Australia, that if you went out, you can't go back in. So, yes, it's been difficult. My daughter did her housemanship during the pandemic, so she was stuck in ED doing 2 rotations, because the bosses felt that, okay, you've done your ED, you're familiar with the steps, please continue. She was not happy. And the worry, we just keep telling them, please protect yourself, because I can't fly in, you can't fly out. Yeah, but we have all made it through, thank God. And last but not least, I acknowledge my immediate family. My late father, he didn't see me complete my training, actually, but I'm sure he's looking down over me through the difficult times of my training. But I'm so very glad that my mother, Madam Chong, there, has made it so far to see me give this lecture. She's now 85 years old. She's a survivor of colon cancer. Not early stage, but Professor April's team really went for cure. And she is cured. We are so humbled, by the expertise that we have in the hospital here in PPUM. And then my mom had to go and get a second cancer. This is a primary lung cancer. I think it was from the years of exposure to chronic passive smoking, because my dad was a chain smoker. And again, we were very lucky to meet with another team of experts in the University of Malaya Medical Center, Associate Professor Dr. Sivakumar Krishnasami's cardiothoracic team. They also went for a cure at the age of 83. And the care was excellent. And now her disease is largely under control. Of course, we have a lot of drugs available, and this is all guided by Professor Dr. Ho Guo Fang's oncology team. So I've expressed my gratitude to them, and they are very happy that I acknowledge them in my Syarahan Perdana, but I really have to. And of course, my two sisters who are here today, Madam Yasmin Abdullah, who herself is such a strong survivor, and she's been giving a lot of encouragement for my mother and also for the whole family. And Pastor Gwen Choo, she's this dynamic young Reverend pastor who is always very cheerful and my go-to person when I want to vent. They have been very helpful, helping to take turns to take my mother to her so many appointments at the hospital. So this is us at her 85th birthday in April this year. So now I thank you at the end of my Syarahan Perdana. Thank you. I think this is harder than giving a talk in international conferences. Right, okay.
Thank you very much, Prof. Choo, for your very informative and very inspiring lecture. Ladies and gentlemen, I would like to invite Prof. April back to the podium to summarize and conclude today's inaugural lecture.
Thank you very much, and thank you, Professor Choo, for taking us on this inspiring journey, which culminates in this lecture today. To encapsulate, 3 decades of work, or a lifetime's work, really, is something that is very difficult to do in the space of an hour or less. But I think you will agree with me that Professor Choo has done that admirably well. What she has shown is a number of things. In terms of her early career experience, she has shown that breadth of experience is just as important as depth. When you rotate through the different sectors of healthcare in our country, you will understand better what the needs of the country are, and not just in the rarefied environment of the ivory tower. That breadth also means that you're able to identify the niche area that you wish to devote your life to. And while we often, certainly in my field, we often deal with the other extreme of age, unfortunately, the early stages of life are very often underaddressed in our healthcare environment. And we often deal with problems which need acute intervention, but we often don't recognize the consequences of what we do further on in life. And so Professor Choo has also demonstrated to us that as we get better at treating certain conditions, we may inadvertently create new problems, right? Why is it that ROP has become, no, it hasn't really gotten less. It's because we've gotten better at saving these premature babies. And so we're now starting to see the consequences of that. Professor Choo has also shown us that it's important to understand your context, right? Local data generation is important so that we understand whether what we're doing is right, whether we have unique problems that we then have to find unique solutions for, rather than just relying on data generated elsewhere. Okay, so that work, while it may seem to you to be perhaps not as groundbreaking or as important as perhaps some fundamental research on how vessels are generated, it is important for us in Malaysia. It's important for us to be able to locally contextualize our management of these very premature babies. And so finally, I want to say that nobody does this alone, right? Nobody who reaches this level of success does this alone. And Professor Choo has demonstrated that her pinnacle of success has been made possible by teamwork, by her colleagues in her department, by the nurses and other support staff in the hospital, and even, yes, even her trainees and her students who have probably helped to keep that fire of curiosity burning brightly within her. And of course, I would echo what she said about family. Without family, we are nothing. Without family, we will not have this motivation to keep going, even when the journey is very arduous and long. So thank you, Prof. Choo, for sharing with us this privilege of knowing about your journey. Thank you for staying with us for so long. And I hope that this will not be the end of your journey with us and that we can count on you in years to come. So please join me in congratulating and appreciating Professor Choo Mei Mei.
Thank you very much, Prof. April, for chairing the lecture today. And thank you, Prof. Choo, for the very inspiring lecture. Ladies and gentlemen, this concludes our event for today. Thank you for sharing this momentous occasion with Professor Dr. Choo Mei Mei. I would like to invite Professor Datin Dr. Hajah Nurlina Ramli, Head of our Department of Ophthalmology, to present a small token to Prof. Choo from the Ophthalmology Department. To commemorate today's event, a photography session will be held at the end of this event. I would like to ask Prof. Choo's family members, friends and colleagues to stay seated for the photo session. Refreshments are served in the synapse, which is just one floor above us. Thank you again, everyone. Thank you very much. So we'll proceed with the photography session. Firstly, I would like to invite on stage Prof. Choo Mei Mei's family members.